Welcome to today's lecture on potassium homeostasis and hypokalemia. We will discuss mechanisms regulating potassium balance, causes of hypokalemia, and clinical presentation including muscle weakness, cardiac abnormalities, and decreased urinary concentrating ability. Potassium balance in the body is maintained by the kidneys and intestines. The distal convoluted tubule and collecting duct regulate renal excretion of potassium, while the intestines absorb potassium from the diet. Intracellular shifts also influence potassium balance. Hypokalemia can arise from various underlying causes. Medications such as diuretics and laxatives can lead to potassium depletion through increased renal excretion. Vomiting or diarrhea can also result in potassium losses. Renal tubular disorders, including Bartter syndrome and Gittelman syndrome, are inheritable conditions that cause excessive urinary potassium wasting. Hyperaldosteronism, characterized by excess aldosterone production, can lead to potassium loss. Additionally, metabolic alkalosis, which occurs in conditions such as excessive vomiting or the use of certain medications, can contribute to hypokalemia. The signs and symptoms associated with hypokalemia can vary depending on the severity of potassium depletion. Muscle weakness is a common manifestation, affecting both skeletal and smooth muscles. Patients may experience fatigue, generalized weakness, and muscle cramping. Cardiac abnormalities can also occur, including palpitations and abnormal cardiac rhythms, such as ventricular arrhythmias. Furthermore, hypokalemia can impair urinary concentrating ability, leading to increased urine output and polyuria. To diagnose hypokalemia accurately, several laboratory tests and clinical evaluations are performed. Measurement of serum and urine potassium levels provides insight into the magnitude of potassium depletion and helps identify the cause. Arterial blood gas analysis can help assess acid-base disturbances associated with hypokalemia. Electrocardiogram, ECG, findings, such as flattened T waves, U waves, and ST segment depression, can indicate potassium deficiency. Renal function tests are crucial to evaluate renal tubular function and the overall health of the kidneys. The management of hypokalemia involves addressing the underlying cause, assessing the severity of potassium depletion, and considering the patient's clinical status. Treatment modalities may include oral or intravenous potassium supplementation, correction of associated metabolic disturbances such as metabolic alkalosis, and adjustment of medications contributing to potassium loss. The choice of treatment depends on the individual patient, with severe cases often requiring prompt intervention to prevent complications. Severe or chronic hypokalemia can give rise to various complications, including rhabdomyolysis, renal dysfunction, electrolyte imbalances, and cardiac arrhythmias. Rhabdomyolysis, characterized by muscle breakdown, can lead to acute kidney injury. Electrolyte imbalances, particularly magnesium deficiency, can exacerbate the effects of hypokalemia. Cardiac arrhythmias, such as ventricular tachycardia or fibrillation, are potential life-threatening complications. Long-term prognosis depends on the underlying cause and prompt management of hypokalemia. Comorbidities associated with chronic potassium imbalance, such as hypertension and cardiovascular disease, should be considered during evaluation and treatment. Hypokalemic periodic paralysis is a genetic condition characterized by episodic muscle weakness and low serum potassium levels. It is believed to result from abnormal ion channel function, leading to temporary muscle membrane depolarization and inactivation. Episodes of paralysis can be triggered by factors such as strenuous exercise, high carbohydrate meals, stress, and certain medications. Managing hypokalemic periodic paralysis involves preventing attacks through lifestyle modifications and pharmacological interventions. Bartter syndrome is an inherited renal tubular disorder characterized by hypokalemic alkalosis and urinary potassium wasting. It is caused by mutations in specific genes encoding ion transport proteins in the thick ascending limb of the loop of Henle. The disorder manifests with salt wasting, resulting in polyuria, volume depletion, and electrolyte disturbances. Treatment aims to correct the underlying electrolyte imbalances, manage volume depletion, and mitigate long-term complications. Gittelman syndrome is another inherited tubular disorder affecting the distal convoluted tubule, resulting in potassium and magnesium wasting. It is caused by mutations in the SLC12A3 gene, which encodes a sodium chloride cotransporter. Clinical manifestations include hypokalemia, hypomagnesemia, metabolic alkalosis, and renal salt wasting. Treatment focuses on electrolyte replacement and management of associated abnormalities. Little syndrome is a rare genetic disorder characterized by hypokalemia caused by increased renal sodium reabsorption. It is caused by mutations in genes encoding epithelial sodium channel subunits in the distal nephron. Little syndrome presents with early onset hypertension, hypokalemia, and metabolic alkalosis. Treatment involves targeting the underlying genetic defect and using medications to block the excessive sodium reabsorption. Diuretic medications, commonly used in the management of hypertension and edema, can cause hypokalemia through increased urinary excretion of potassium. Loop diuretics, thiazide, and potassium-sparing diuretics have different mechanisms of action but can all lead to potassium depletion. Managing diuretic-induced hypokalemia includes potassium supplementation, adjusting the diuretic dose or regimen, and monitoring serum potassium levels to prevent complications. Primary aldosteronism is a condition characterized by excess production of aldosterone by the adrenal glands, leading to potassium loss. Increased activity of the mineralocorticoid receptor in the distal nephron results in enhanced renal sodium reabsorption and potassium excretion. Hypokalemia is a common finding in primary aldosteronism. Treatment involves surgical or medical management to control aldosterone production and normalize potassium levels. In conclusion, maintaining the right amount of potassium in the body is crucial for good health. Hypokalemia, a condition of low potassium levels, has important implications for patient care. Understanding its causes, symptoms, and diagnostic approach is vital. Treatment strategies and possible complications, as well as genetic disorders associated with hypokalemia, should also be considered. Join us for our next lecture on electrolyte disorders to learn more.